Mr. Chairman, ladies and gentlemen, it's a pleasure for me to speak about tailoring imaging for swallowing disorders, and I had slightly to change the title because in clinical terms we do not restrict the radiological workup to dysphagia. So to go more in detail with this, on the right side you see the radiological classification of swallowing in our tradition. I will come on that later on. And here you see the whole bunch of symptoms which have to be integrated, whether they are alone or together. And the tailoring has to focus on dysphagia, means difficulty in eating or drinking. Aspiration is a kind of dysphagia, but is your suspicion or the suspicion of clinicians that the patient will or may aspirate. It's not the consumption of the patient alone, because there are so-called pseudo-aspirations of people who have some affection in the larynx, predominantly from reflux or flus, and they might think to aspirate. So you really have to classify that. There is a simple test: ask if a glass of water can be drunken or test it. Globus syndrome is nothing psychological. Globus syndrome is something which is somatic in the sensation, might affect psychological dimensions, but at last, this is a somatic, very important symptom, predominantly caused by gastrointestinal problems, let's say reflux as the most common cause in over 90%. Non-cardiac chest pain is the lost patient who didn't have any cardiac disease and may be mixed in the symptom with a retrosternal problem, maybe mixed with dysphagia or globus, so it belongs to the head and neck, as does the esophagus with reflux and other problems like bariatric surgery. So going on swallowing doesn't mean that we are allowed to restrict to the oropharyngeal swallow. So the strengths of videofluoroscopy as the standard procedure and the gold standard for the whole swallow, for screening the whole swallow, is the investigation of function and morphology. It's not solely a functional study, because dynamic morphology like the Schatzki's ring or some more rarer circumstances in the pharynx are only seen during action. So there is morphology we do not see on still images alone. Another strength of videofluoroscopy is the evaluation distal to a severe stenosis. Look, this combination of a web, this is not the epiglottis, this is a huge membrane stenosis in the pharyngoesophageal junction, and here you see dyskinesia, and you might think that an endoscope cannot pass easily. As well, multiple stenosis in the esophagus are best seen on radiography. So radiography is really a complementary, beautiful friend of endoscopy. Another strength of videofluoroscopy is visualization of different materials. You can use marshmallows, but there where the patient is used to it. Here in Europe, usually we take barium and bread. You can be just very creative in that. But there is one standard. Schatzki himself published his study about the ring and stenosis with tablets, and the tablets with 14 or 13 millimeters, they are a measuring tool. You let the patient swallow if there is no restriction in the oropharyngeal swallow, and then you can even measure the narrowing here in a fundoplication stenosis. You can measure the narrowing by visualizing directly at the place of the stenosis. There are weaknesses of videofluoroscopy, not many, but we never exclude malignancy. I saw some esophageal carcinomas, they even had been overlooked by endoscopy because they may be in a condition that even the endoscope can fail, and we never ever should exclude malignancy. What we can exclude is a manifest morphologic stenosis. So no exclusion of malignancy is not really a weakness, but it is a weakness, because usually any patient with dysphagia has to get an endoscopy, even if you find a pharyngeal reason. I will show you later on why always the oropharyngeal swallow and the esophagus has to be combined. Low availability is the most common drawback of this method. Reza Shaker, who is really the leader of the swallowing community in the United States and a good friend of our European group, Reza Shaker states that he doesn't have radiologists to do the swallow in his country, so he has to go a workaround. In his department, almost every patient gets the analysis by a radiologist. So this is a call to all those who are involved in education. Bring back the swallow to radiologists. We are a very small group, starting with Donner in the early 80s, and Ekberg and a lot of other colleagues are deeply involved in that interesting clinical field. Well, common causes of swallowing disorders. I do not like to present you any kind of list, more a systematical approach, how to order all those diseases that you know. We are extremely weak in differentiation of neurological diseases. You are, on the other hand, quite sensitive to detect them. So we are not differential diagnostic experts. We are sensitive to see where the problem of the swallow is taking place. So we divide the oropharyngeal causes in neuromuscular and postoperative and dynamic morphology, like scars, postoperative immobility of parts of the pharyngeal wall. So the dynamic morphology has to be differentiated from the pure function, like we have in muscle weakness. There is no morphologic order in the macroscopic dimension. So dynamic morphology and function is always the name of the game. The esophagogastric part of swallow, why gastric? The stomach is included in the swallow because, for example, a bariatric stenosis of the mid of the stomach can make problem to bariatric patients, and they might have then motility disorders, and they can come up to the pharynx and even can have symptoms in the ear. So even the stomach has to have a short glimpse and is always included in questionable cases. And again here, motility disorders like achalasia or severe unspecific motility disorders as well are integrated in the oropharyngeal and esophagus and esophageal picture, and only radiologists are able to screen the whole swallow within some minutes. A good study takes 30 minutes for an experienced radiographer. A radiologist takes 30 minutes, 2 or 3 minutes of taking the history, about 20 minutes to take the study, and about 5 to 8 minutes to do the report. So the whole time involvement of the room and the radiologist in my department is 30 minutes. What causes we might see? The pharyngeal phase is the clue for the tailoring of the examination. The aspiration is that what we fear. There are few people dying during a barium study, but those are debilitated patients who got the order, drink that. It was in old times when a lot of stomach examinations had been done. Drink that, and the patient drinks and says, well, I cannot, but if the doctor says, there's very few cases. And they didn't die from the barium, they were dying from the cardiac shock. I had one such a patient. I was happy not to investigate this lady. That was an emergency case. It was an elder patient after stroke, about 80 years, and died from cardiac shock, and the lungs were pretty empty of barium. It was just a normal aspiration. So aspiration is that what we fear. We have to explore the patient for that, because we never should give hard solid bolus like tablets in people who have a pharyngoesophageal stenosis. The rest, the tailoring of the rest, we find motility disorder, we find diverticular and stenosis, mild achalasia without dilation is one of the most important diagnoses. Not even manometry is always as sure as the radiologist who can prove the functional disorder by transport restriction. Achalasia with dilation, every student knows from the quiz of the chest X-ray, this is not a problem to diagnose, of course. We see it on the first few. Hernia, postoperative problems, Schatzki's ring in a head and neck session. I will not touch that too much. So how the radiologist is approaching that? We want to be easy. We want to give reports. We do not like to have a one-page story nobody can understand. So we refer our reports to the oral cavity and tongue, to the soft palate, to the epiglottis, to the hyoid and larynx, to the pharyngeal constrictures, to the pharyngoesophageal segment, but last but not least, esophagus and a few to the stomach, and extend it down there as the tailoring demands. I show you data I love very much. We did it on an ESCR meeting in '98, where we had 2,003 patients that time, and concentrate only on this red arrow. This field shows you the 7 functional units and their percentage of involvement. And here you see patients who have a lot of functional units simultaneously involved. And here you can say there are 8%. Yeah? 8% of the patients have had combined problems of the pharynx and the esophagus, and we estimate, we don't have clear data about it, or we estimate that 2% of these 8 are really of a high clinical impact. So you find patients that last 2 or 3 in 100 who really have a problem if you don't see the whole swallow. Usually, just to give you an example, this is the pharynx. In a stroke patient, you find a lot of problems with retention and aspiration, and then you have an achalasia or an old heart stricture of reflux. These are poor patients because they get then a beautiful logopedic training, they can swallow bread, and then they regurgitate it from the esophagus. Nobody will do endoscopy on these people in the wheelchair. These frail elderly are really in danger to be lost. Or patient with a mental problem who cannot communicate with us. They are coming with a service person in your department. And I had one of them who had a severe neurological problem and came for aspiration diagnosis. And this was about 20-year-old lady with achalasia of 10 centimeters. Nobody wanted to endoscope this lady because she was moving so fast because of very severe derangements. And these are special cases, but we should not forget them. Tailoring the examination. We have to keep it simple in some way. Aspiration starts with 3, 10, 20 milliliters. Barium, isoosmolar contrast material. If you fear the barium, adapt consistency, diagnostic. If nobody knows the disease, and therapeutic. If you handle the therapist who is not happy with endoscopy alone. Dysphagia globus, non-cardiac chest pain, and others. Here you start with normal barium. Maybe you use a tablet to depict the stenosis. Food mixed with barium, double contrast adds value. Here you see the patient. Only thing of clear we have to see the patient upright and prone and supine. But motility without gravity is mandatory for the esophagus to evaluate motion and dynamic morphology. The Schatzki's ring is seen in prone or supine. I do both because sometimes it's better here or better there. That is maybe about 50%, so you have to do it in both directions. Let's have a look to a classical situation of an old person, multiple strokes, bleeding, whatever it is. Here we see a combined disorder of many functional units. There is bread and barium, retention in the mouth, sticking to the palate. Of course, you can see it clinically, but then it's interesting what's going on afterwards. Here we have retention in the vallecula, in the hypopharynx, and we have an aspiration after the swallow because of the retentions. It is a classical picture, and if you see the approach in the 7 functional units, like it is published and easily to access, you can have a quick report without measuring all the tongue movements and whatever, which is done by dedicated experts for measuring the oropharyngeal swallow. My group does not think that the community will do that specifications. Of course, we look the relation of the contrast transport around the pharynx and the nasopharynx and the esophagus. And we should not forget the nasopharynx. Of course, if the patient tells you that his noodles come out during eating often, then of course you know that is a nasal regurgitation. But nevertheless, it can be of interest and is a fixed part of the pathologic findings we may detect. Here it is easily, it is a post-operative patients, and you see these partially resected soft palate and contrast material entering the nasopharynx. And we see retentions in the pharynx, and we see a nice transport over the upper esophageal sphincter, which is very important for the neurologist, is very important for the surgeon to decide whether those rare cases would take profit from myotomy, could be involved here. So it is very important to add videofluoroscopy in the patient workup to fiber endoscopic dynamic evaluation. So aspiration, what Donna brought so beautifully into our mind, together with Bronwyn Jones and Sherilyn Logeman, I love very much to remember the time of these great clinicians. We have to divide aspiration into pre-deglutitive, like you see it here. The patient aspirates before the swallow. Look here at the aspiration. Before the involuntary, the automatic swallow is the more precise expression. Before the automatic swallow starts, already aspirates. Usually this is a discoordination between closure and elevation of the larynx and what comes down from the back of the tongue. Then the second important one is the intradeglutitive aspiration. Here it is easy. This is a partially resected larynx, and you see during the intradeglutitive phase, the contrast material is pressed into the larynx below the level of the vocal cord, and this is the definition of aspiration itself. In neurologic cases, often I am asked, is this intra or pre? Because the most common intradeglutitive aspiration is just at the border to pre-deglutitive. So don't scratch your head too much about pre and intra. You just judge it. If you have three different things, never ever the patient is only in one. So it is very often border-like between pre and intra, but you will find clear pre and clear intra like this one. And you will find patients aspirating on different time points. So this has to be evaluated systematically. So let's go to the post-deglutitive aspiration. I give you a frontal view because I want to see, is that symmetrically? You might say, oh, that's more on the right side. But this is because of the head position. This is almost a retention of barium in a kind of symmetric way. And we have post-deglutitive aspiration. I would say in this case it is a more severe, middle to severe aspiration of around 10% of the bolus, because we cannot take the volumes directly, so we have to judge it. But anyway, we are not the person as a radiologist who define can eat or drink. I don't give a statement of this because this is, as in pneumonia in the chest X-ray, is a clinical diagnosis. Is forbidden to eat. If you see a patient with aphasia, cannot eat at all, of course, this is easy. But anyway, you tell what you see, and you do a precise report on what had happened, but you don't say the patient may or may not eat or drink. This is an interdisciplinary decision. Very important, oh, this was too fast. Very important is the symmetric pharynx. Here you see a right unilateral paresis. Here we have really a palsy of the pharyngeal wall on the affected side, often after local operations, neck dissections, whatever. And here look at the sphincter. The sphincter is as well asymmetric involved by a dyskinesia of the right part of the cricopharyngeus, and I wonder that is in the textbooks you don't find these, but this is the problem, and a unilateral myotomy can help in such problems if the conservative treatment doesn't work. Very important is the dyskinesia of the upper sphincter. All of us learn that if it is mild, it's no problem, it can be normal. Well, a lot of people, almost all people have low back pain, and this is the low back pain of swallowing, the dyskinesia of the upper sphincter. Because the dyskinesia of the upper sphincter is almost always involved with an esophageal problem, most commonly reflux, of course, and shows us here is something with the motility that maybe not hinder the patient in life, but is important because it explains symptoms. And the explained symptoms relieves fear, so you are touching just the ground of therapy by telling the patient, and you are allowed to do so, that you didn't find a severe hindrance, but there is some problem, and this may symptoms. So it is important. But this is not a mild one. This is a dyskinesia where you can say it's about over 40%, and these can make problems. And now the video doesn't run. Now here we see it. So here you can see that it is more than 50%. I say this is a dyskinesia should make clinical problems. Below 50%, it's uncertain. So another story is the very severe problem. This is a double dyskinesia of a very severe neurological disorder, and in this case, the sphincter doesn't open at all, and the part of the cervical esophagus is doing a second one, is doing a second bar, as you can see. There are two bars. And we have a transport problem up here, so a myotomy may fail. This is just a catastrophe case. Nobody should forget the Senker's diverticulum, and I don't like only to have a photo of it. I would like to show the video to the surgeon, because this is proof of indication of surgery. Here there is the compression of the pharyngoesophageal segment, and this defines the indication for operation. It's not interesting, the size of the diverticulum. This is about not even 3 centimeters, and you will find clinicians, unaware clinicians, who say, well, this X-ray small diverticulum, you can live with that. And then you have an elder patient coming 8 years later, marantic and having 50 kilos and such a diverticulum. So we have to be function, and we have to integrate function and morphology. Radiology, conventional radiology and carcinoma, never ever, but that's untrue. The cervical carcinoma often is a patient who cannot tolerate endoscopy, and then they are left in a limbo because nobody anymore will help them with their problem. So the cervical carcinoma often refuses endoscopy even if sedated. So the radiologist then has to see that, and it is difficult to detect. The cervical carcinoma sometimes is visible only in 3 parts of a second. It's because the transport speed immediately below the sphincter is pretty high. Then there is, just coming to the end, you see I am going down. I do not like to show too much of the esophagus. It's not the topic in this session. But this is the normal esophagus in the standing position of a young adult. An elder one will have a low motility problem. This is not normal, but it's okay with elder people. But that is what you should see. There is something different. There is something different to see, and this is the so-called support level. I like very much this old radiological term. This is a patient who cannot open the sphincter, no dilation, no morphology, normal endoscopy, and this is a kind of achalasia. May produce globus, may produce dysphagia, but is not dangerous. The patient has explained this is a mild form of achalasia. Come if you have troubles, and let you monitor in a functional unit. We send these patients to my university clinic, and then they are monitored, and maybe 10 years later they need dilation. We don't have data of the long-term run of those mild forms of achalasia, but they are much more common than the severe form everybody knows. Then there is something which really is a responsibility of radiology, and this is eosinophilic esophagitis. I, for myself, was misinterpreting this small caliber esophagus very long, and Mark Levine helped me a lot because he defined the small caliber esophagus. We are thankful for that. And in our esophageal community, in our interdisciplinary esophageal community, we know that the Tschatzky ring is strongly associated with the eosinophilic esophagitis. And it's not only young men. This is I remember, 70-year-old lady, and she came after 30 years of suffering with a myopathy in the pharyngeal stage. She came to my office, and I didn't expect that, but I found a small caliber esophagus, and the combination in that patient of pharyngeal and esophageal problem showed me that we have to be specialized radiologists, but a little bit general too. Beautifully, we can now measure the stenosis with endoflip, and here we have the endoscopic view of this mosaic, shaggy picture. Here the Tschatzky ring of this lady is demonstrated with a tablet got stuck, and here you can measure the tablet and tell exactly the width of the stenosis. So my conclusion: videofluoroscopy for swallowing symptoms provides a descriptive overview of function and morphology of the entire swallowing tract. In diagnostic studies of symptomatic patients, it is important to evaluate morphology and function of the oropharyngeal and esophageal phase with a tailored but complete protocol. This approach avoids missing of simultaneous pathologic conditions of the pharyngeal and the esophageal phase. We have literature on that for young people for some $4 or $5. As for iPad, we have the complete scenes, exactly this one, remodeled on the iPad under University Publisher 3.0. And then my dear friend and teacher Ole Ekberg has brought together a book, Clinical and Radiologic Approach to Dysphagia in Springer with this European book line. It's a very beautiful book and it's very complete, but I would buy both of them, the Reza Shaker book and the Ekberg book. So you have the competence of swallowing on both sides of the Atlantic, and this, the DRS and the ESSD, our Young Society of Swallowing Disorders, are in very deep friendship and cooperating a lot, but there are different views, and these two books really give you everything you need for a life of swallowing. The life of swallowing has ended for this bird, is from a museum in Austria, and is a cormorant, and I think it's a cormorant, and had swallowed this fish and was found dead, aphagic and asphyctic on the beach of the Danube, and went to the Navy Museum, the small Navy Museum of Austria. And I would like to say as the final sentence, videofluoroscopy is an ideal first test for evaluation of dysphagia, complementary to other functional and morphological investigations. And the best choreography of tests is provided by our ability to cooperate among different disciplines. Thank you.